Hello, Orlando. This is London calling.
Hello, London. Good to talk to you.
Hi, Bernard. I guess are you
Hi,
going?
Phil.
Are you going to do the introductions to your panel?
Yes, I'm going to kick off by asking each of our panel members to introduce themselves. But firstly, we've got a great opportunity because Don Berwick, who's the chief exec of the Institute for Healthcare Improvement here, whose conference we're speaking from, is able to join us for the first 10 minutes or so of this broadcast. So I'm going to start by asking Don to introduce himself, but also to talk to us about cost and quality. Don.
Thanks, Bernard, and thank you for the chance to join you over in the UK. I wish I were with you in person. As Bernard said, we're talking to you from the Institute for Healthcare Improvement's 21st Annual National Forum on Quality Improvement in Healthcare. Actually, national is the wrong word. It's quite international. There are 41 nations here, 5,300 people here in Orlando, Florida, and 15,000 connected by satellite feeds in the United States and in many other countries. It's a very, very busy time for us, and I do apologize for having to leave what is going to be a fascinating panel, but I didn't want to miss the opportunity to greet you all and to talk a little bit about what you're going to be talking about. Concerns about cost in healthcare are not just the dominant issue in American public policy at this very moment, but they're, of course, global. I visit no countries now in which I don't have deep conversations with leaders, political and healthcare leaders, who are concerned about costs of healthcare and the opportunity costs that the rising healthcare costs pose for other important investments of resources. So we share that in common. It's particularly a festive time about cost concerns in the United States right now, as you know, because we're deeply in the midst of a congressional debate trying to get legislation passed at last in our country that will cover the uninsured. Nearly 50 million people in America don't have health care insurance, and our Congress is struggling with how to close that gap at this very moment. We'll expect votes later this month and hopefully a bill on the President's desk in January. As that debate has progressed in my country, if you were to tune into C-SPAN or one of the networks that tracks the Republican-Democrat debate going on in our Senate right now, for example, you'd notice a kind of dyadic, head-to-head debate about competing problems, competing issues in trying to provide full coverage. The issues are all center on how to cover the cost of getting everybody the insurance they need. The proposals tend to come in two versions. Either raise the money somehow, raise taxes, or do something in terms of recovery of money that we could then invest further in healthcare. It's kind of surprising to you, I'm sure, in the UK, because we're spending 16.5% of our GDP on healthcare, and UK is only spending about 8 or 9%, 8.5 or 9%. Nonetheless, in the U.S., one proposal is cover more people by finding more money. Tax insurance premiums, tax the wealthy, tax insurance companies. The other part of the proposal is cut something, do less for something, limit care, cover more people, but do something that limits how much we pay for a procedure or how much we'll cover in the benefit structure. So it's either find more money or do less good. That's the way the debate's going. The Institute for Healthcare Improvement, IHI, and I think you have what I think is a richer idea, a more textured view of the problem of cost and how to deal with it. And the hallmark idea is to begin to regard cost itself as a quality. My close colleague and now IHI board member, Brent James, talks of three kinds of outcomes of process: technical care outcomes, service outcomes, and cost outcomes. And I think that framing, that cost as an outcome of the way a process functions, is a fundamentally important idea and guides our work. This is not an easy sell. For a long time in healthcare in America, and I think in other sectors as well, an average critic or an average participant in a system of production, like healthcare, would regard cost and quality as competing with each other, as a trade-off issue. Higher quality, higher cost; lower quality, lower cost, as if one has to sacrifice quality for cost reduction or cost control for higher quality. We don't believe that. We believe, as Brent James argues, cost is a property of a process. The cost of a healthcare system is determined by its design, and that inventive, creative, progressive learning processes, learning organizations can learn their way in any industry, including healthcare, to designs of production whose characteristic costs are lower than the less sophisticated and less developed designs. We in IHI believe it is possible to improve quality and reduce cost at the same time. We're not seeing that in the congressional debate because it's a rather sophisticated technical matter. It really is for the providers of care, the deliverers of care, the healthcare systems themselves, whether in the UK or in the US, to be the inventors of the new processes, the new approaches that can reduce cost and raise quality simultaneously. One wouldn't expect that to emerge from a public policy arena. The key is process thinking. It's begin to see production as a system, production as a process, to understand that whether we're talking about a hospital or the continuum of care in the health economy, or indeed the nation as a whole, that the provision of health and healthcare services to a population is the function of a very complex system which can be continually improved. In the Institute for Healthcare Improvement, we frame this goal as the so-called triple aim. Triple aim is the most important research project of IHI's current portfolio. By triple aim, we refer to three goals at once. The improvement of health care for individuals so that that care be safe and effective and patient-centered and timely and efficient and equitable so that people who come into the care system get the best care they possibly can. That's goal one. Goal two is improving the health of the population. That has to do with precursors of illness, risky choices, substance abuse, violence in society, accidents and injuries, smoking cessation, obesity, patterns of nutrition and exercise, domestic violence and its consequences, working upstream on the things that generate the need for health care in the first place. And finally, reduction of per capita cost. The triple aim is better health care, better health, and control and reduction of per capita cost. As we in the U.S. struggle to find out how to cover our population and to find the resources to do that, we want to look for those resources within the healthcare world by the redesign and continual improvement of complex systems aimed now at the triple aim. In the U.S., we suffer from not having stewards of the triple aim. We don't have the benefit in the U.S. of many integrators of care who regard the care of a population and the resources needed for that population to be their responsibility to bear that burden. We're trying to create such organizations. In the old days of the Health Maintenance Organization, we had them, but those days have gone, and we're trying now to resurrect some form of integrated care design. In the UK, you do have that organization, at least at the national level. That's the National Health Service. It's the integrator for the nation. And as you've moved down toward health economies in the UK, you're looking for opportunities, better ways to vest responsibility, stewardship for the care of populations in well-managed, well-run entities that understand process thinking and are capable of redesign. In order to do that, to redesign healthcare to achieve the triple aim, better care, better health, and lower cost at the same time, it's going to take a vast array of competencies linked together. That's why I'm so excited to be talking to HFMA and your members, both the U.S. version and our sister organization in the UK. Just as in the improvement of processes of other types with other objectives, we've had to learn to build bridges to other competencies, engineering sciences, statistics, cognitive sciences, social sciences, as we had to build bridges across disciplines to invite mental health professionals and community-based agents of change for healthcare to work more closely together to achieve better health and healthcare. We're at the same juncture with respect to cost. If cost is a quality, if it is a property of design, and if we're going to redesign, we have to have the knowledge of finance and cost deeply embedded in the quality movement. We've got to do that. And to reinvent it or act as amateurs would be a big mistake. And so to build bridges to HFMA and the competencies and knowledge that you can bring to the table and make sure that the redesign of healthcare is informed by the best possible knowledge about finance, financial structures, cost, and its consequences is the only way to do it in a scientific grounding. So I see this as the progression of science. The partnerships with HFMA and the leaders of healthcare systems and the redesigners who want to make health and healthcare better for the communities is an essential resource. IHI, the organization that I lead, our purpose is to build bridges. The way we make progress is to create intersections that otherwise wouldn't exist. The same exact agenda and competence is true of Bernard and the National Health Services Institute for Innovation and Improvement, a great meeting place, a place in the UK that can provide a home for intellectual exchange of the highest quality so we can do what we want for our populations. To do that, as Dick was saying before we joined you, we need common language. We need to learn to talk each other's language and end the schism between the world of finance and the world of delivery, which never served us well at all. We are in the same game, and that's to deliver health and health care to our populations at a price we really can afford. We're confident we can do that through redesign, and we badly need this kind of exploration that you're engaged in order to make that work. So those are some of my opening remarks. I'm very excited. I'm envious that you get to be in the panel, and I have to go on to other duties, Bernard.
Don, that's fantastic. Thank you very much. So what we're now going to do is introduce the other members of the panel. When we speak here and when you speak to us, there's a short delay. So just excuse us if you ask a question in a few moments, that there'll be a short delay before we reply, because we won't hear. But I'd like to pass over to someone who I know will be very, very familiar to those of you from the HFMA, and that's Dick Clark.
Thank you, Bernard. Good afternoon, everyone. I wish I could be with you. I remember last year when I attended the annual conference, you conveyed on me honorary fellowship in the association. I believe I'm the only one in the world that has fellowship in both HFMAs, so that honor was very, very heartfelt and very much appreciated. But I am glad that I'm able to participate, at least electronically, at your meeting, and hopefully we'll, through this panel, be able to close the gap or at least reduce the size of the pond that separates us. For those of you who don't know, I'm Dick Clark, the President and CEO of the Healthcare Financial Management Association in the United States. We are have a very close working relationship with the HFMA in the United Kingdom, two separate organizations, but very much tied together with common interests and common goals. The relationship between the two associations goes back actually more than 30 years and has been highlighted primarily through an exchange of members that, again, we've done for about a 30-year period of time. So I'm very, very excited about this opportunity to be with you, though electronically as opposed to in person, and I look forward to the panel discussion.
Thanks, Dick. So now, Maureen Bisignano.
Hi, my name is Maureen Bisignano. I'm the Executive Vice President and Chief Operating Officer at the Institute for Healthcare Improvement, the host organization for the meeting that you're joining electronically. You may wish you were here. We're talking about wishing we were back with you in London. We're in Orlando, Florida, and it's pretty beautiful weather here right now in this part of the United States. This meeting is different because, as Dawn said, this is our 21st of these meetings here in the United States. And with 5,300 people, until this year, almost every one of them was a hospital CEO or a board member, a physician practicing on the front lines, or a nurse or pharmacist. This year, we're getting many more chief financial officers and financial people of all kinds at this meeting. And I think it is a real step forward. As Dawn said, we need to build bridges between all of the different elements of the senior teams in healthcare if we're going to solve these cost and quality problems. In the past, we would sit around a senior table and we'd hear the finance people speaking in one language and the CEO speaking in the language of strategy and building and investment, and we'd hear the clinical people speaking in their own language, and the level of understanding across that senior table was really not complete. So that's why we believe that the divisions between will cost improve if we invest in quality, or will quality improve if we invest with more money, I don't think we've had the right conversations yet. This meeting, of the 5,300 people, we have several hundred who are finance people here. And we're just having conversations around different board tables at this meeting that haven't happened before. We're delighted. We think it's a first step and a first bridge, and need to continue this kind of conversation between finance and quality. Thank you.
That's Maureen. And David Dalton.
Hello there. Unlike Maureen, I'm delighted to be here, and I'm quite pleased that I'm not in London with you at the moment, because as Maureen said, the weather here is absolutely fantastic. Those of you who don't know me, I'm David Dalton. I'm Chief Executive at Salford Royal. And this has been a fabulous forum. It really has. I've listened and learnt a lot, and one of the principal discussions is looking at this connection between quality improvement and cost improvement. I'm sure everybody in the audience knows that harm happens in our hospitals. It certainly happens in Salford Royal, and we've a plan to do something about it. But we also know that those patients who we give an infection to, who have sepsis after their operation, have a fall, or get the wrong medication at the wrong time, stay in hospital longer than those that don't. And at Salford Royal, they stay in about 1.8 times longer than people who don't receive harm. I think we've got a challenge then in looking at how we can understand where that instance of harm takes place, and how we can look at the reduction in harm to liberate occupied bed days. We have choices, I think, at the moment to decide whether we want to use those liberated bed days to admit more patients in and generate more revenue, because that's what we've been doing so far. As we all know in the UK, the money is going to be running out in about 15 months' time, and our choice is whether we want to continue to pursue the pound and admit more patients into those liberated occupied bed days, or whether we want to take capacity out of our healthcare systems. And in the arithmetic that we've done at Salford Royal, if we were able to reduce the instance of harm that our patients experience, then we would be able to continue providing the same level of service to our patients with 74 fewer beds. And I think that's our big challenge, is looking at how we can understand where harm takes place across the 850 beds in my hospital, and know how we can start reducing the capacity proportionate to the benefits that we get from pursuing our programmes of improvement in patient safety and quality improvement. So there's a huge amount that I'm learning here over the last few days, and I'm just delighted to be on the panel with you at the moment.
Great. Thanks, everybody. You had the chance to hear a little bit about me from the video at the beginning, so I'm going to hand back to Phil, and we'd love to answer your questions.
Thank you very much, Bernard. I'm very much aware that we can see you, but you can't see us. And of course, you can't see us, so you don't know how warm and sunny it is here in London. You should really be jealous that you're not here. But just to let you know, we have about 200 people, between 200 and 250 people, I think, in the session here. We have lots of questions, so it would probably be good from our point of view if you could be relatively brief in the questions, in answering the questions, so that we can get through more of them. And what I'm going to do, I'm going to ask a member of the table that drew up the question to ask you directly, so you'll hear the voice of the person who wants to ask the question. So we'll start. I was going to start with a question of my own, but actually we've got so many questions. I'll leave that one till later. So the first question, please, is from table 23. Which is Bill Jones, who I think is a non-executive director at Calderdale and Huddersfield Acute Trust.
Thank you. Thank you. Good morning, America.
Morning.
Hi.
Does the insurance-based healthcare system in the USA best drive both quality and cost? Thank you.
Okay, perhaps I could ask Dick and Maureen to answer that first.
Yes, the U.S. payment system, the way in which funds go from the sponsor of care, the government or the employer, to the provider of care, is fairly convoluted. And so the answer is not a simple answer. There are third-party payers or insurance companies who are working very diligently to try to relate the level of payment to the outcomes that are being achieved. In other words, the quality of care that is being achieved. There are other payers who are not doing much work in that regard at all. What we are seeing is a lot of experimentation. There are a variety of different pilots that are running both on the private side by private health insurance companies and on the government side, predominantly through the Medicare program, which is the program for the elderly here in the U.S., to change the way in which the incentives work in the payment system, the idea being to pay for value or to pay for performance. Those pilots are relatively small at this point. I think most of us believe that they will be somewhat indicative of what will be the future payment methodology that both the private side and the public side will use. But at this point, they are relatively small, and we are still learning. So the intent, I believe, to answer the question, the intent is to, in fact, move toward a payment system that is much more recognition, that recognizes quality much more in a significant way, and to reward those providers who provide higher levels of quality, or potentially punish those providers who provide lower levels of quality.
And I'll just give you one example of each, the reward on the upside for improved quality and the penalty reward for poor quality. In Massachusetts, the Blue Cross Blue Shield insurer has developed what they call the alternative quality contract, which means that an organization will sit down with the insurer, a healthcare or hospital will sit down with the insurer and negotiate aims in improvement. The aims are aggressive. They're saying, if we can move from this level of quality and reliability for cardiac care or safety in OB care to this level over a relatively brief period of time, there is a big financial incentive at the end of that time period. What is happening with that potential that for enhanced reimbursement is, again, the whole senior team is coming together, creating a very aggressive quality plan and learning how to focus on improving those process metrics in hopes that they'll earn that extra revenue. And I think it's really working in the small experiment so far. On the other hand, Dick mentioned the penalties for no pay for never events. And the government has classified a group of about 11 incidents like certain medication errors, certain infections, leaving a sponge in after an operation as never events. That is, they should never happen. And what they're doing now is penalizing hospitals financially should those never events happen. So we're seeing pull on the upside and penalties on the downside.
Over to you, Phil.
Thank you. The next question is Table 14, which is Hina Khalid, who is a financial management trainee.
Hi, my question is that for some organisations, improvement in quality require capital investment, which will yield the quality savings in the long term. How do you manage this in this current climate, bearing in mind that all the quick savings and the quick wins and improvement have been made?
Okay, perhaps I might start with that question. I'm not sure I'd agree at all that all the quick wins have been made. In many of the programs that we're engaged in, there are very successful examples of organisations that have implemented specific improvements that have made an impact. But often we find that they're projects that affect 10-12% of an organisation rather than being used everywhere. But your point about the fact that there is an investment that sometimes needs to be made, sometimes a capital investment, and on other occasions a human investment, before one can mount a quality improvement program's an important point. And I think it's true that those of us who advocate improvements in quality haven't been as good as we should have been in the past at calculating the returns on investment fully to take account of both the costs of the quality improvement effort and the opportunity costs of the time of people who are engaged in it. We've developed in the Institute a range of return on investment templates for different sorts of projects which are trying to resolve that problem and be much more upfront about capturing both the costs and the opportunity costs. And we're still seeing some of our programs with very, very substantial, up to 10 times return on investment for the investments that are made. David, do you want to add anything?
Well, I would just say that I agree with Bernard, that I think there is still much more that can be done. And in terms of capital investment, I think the best investment would be investment in human capital, in looking at how we can liberate the talents of our own staff to think through some of the solutions to the problems that they face. I mean, what we found in our hospital is that we've had to look at investing in development programs for staff, looking at developing their own capability for improvement in their own workplace. And that's providing us now with some fabulous returns, that staff are coming up with some great ideas. They want to test the change, their proposals for change, and they want to see whether the change in their practice or behaviour results in improvement that they were expecting. We're publishing the results of that at Salford Royal, and you would be able to see that an awful lot of staff's ideas can be put into practice, and as a consequence we can make improvements to the safety or assure the safety of services that our patients receive. What we have to do is to make the connection in terms of the business case, that there is a return on that investment, and that would return me back to my original statement about understanding how you can liberate bed days and how you can then withdraw those from the system.